Yeah, so my topic is orbital inflammation and Enigma, and I'll take you through few cases, very interesting cases. Okay, and I see most of you are postgraduate students here. Okay, all right, yeah. So when the nation was gripping, in the fear of mucormycosis, and it was actually declared that mucormycosis is an epidemic, and anything which was coming as, acute presentation was considered as mucormycosis. So was this case. A 65-year-old gentleman, all right, in September 2020, he started with acute onset pain and swelling. And then he developed, having a third nerve palsy. And when he was referred to me, he was referred as a case of mucormycosis, all right. He was uncontrolled diabetes mellitus. His ppbs was 300 milligram per deciliter when he actually presented. And this was in October 10th when I saw him in the clinic when it got referred. His best corrected visual acuity was 6/24. Pupil, there was no RAPD, and optic disc margins were blurred. And this is exactly how he presented. Well, a diabetic, mucormycosis could be a possibility, severe pain, rapid progression. So what do we do next? Okay. Now, clinical evaluation, as you can see here, there is severe motility limitation over here. There is no supraduction at all right? So there is definitely a fullness in the superior orbit as well, hyperemia, pain, etc., etc. So what you think is of an orbital inflammation? Of course, yes. Now, what do we do next? We go ahead doing an imaging. So this is what the imaging shows. There is a large diffuse lesion sitting in the superior orbit, okay, in the preseptal as well as the postseptal into the orbit, and this is how it was looking like. Now, what is remarkable over here? When you talk about mucormycosis, we say rhino-orbital mucormycosis. Sinus should be involved, mostly sinus is involved. You see, the sinus is absolutely clear. Usually it comes from the ethmoid sinus into the medial orbit, and that's how it progresses. I'm sure everyone knows about mucormycosis by now because you all have seen it, you have treated it. Sinus is absolutely clear, all right? So I was not too comfortable about the diagnosis of mucormycosis. So what I did was went ahead doing a biopsy, and this is what we did, an incision biopsy, all right? So this came out as a natural killer T-cell lymphoma, a primary orbital. No systemic involvement because we do a lot of systemic evaluation, including a PET scan in this patient. So it was a stage 3, T3N3 and M0, all right? So it was an orbital inflammation. It presented as an orbital inflammation, but on biopsy, it was proven to be a very lethal lymphoma. This is a very high-grade lymphoma. In fact, the patient died after 2 months of treatment, and this is how we go through it. We do a histopathology, and natural T-cell lymphoma, killer T-cell lymphoma needs specific immunohistochemistry, all right, to rule out the type of the lesion. So basic histopathology is not the only thing that you do for lymphoma. The tissue has to go for immunohistochemistry to type it. Now, this is a similar case, a 48-year-old lady. She was complaining of watering for 4 months, eyelid swelling 1 month. You can see that some amount of puffiness in the medial, canthal area and the superior medial orbit, and a little bit of swelling over here. And she has a history of nasal block, allergy, recurrent sinusitis, history of DNS. She is being seen by ENT, there is septal thinning, and she has a strong family history of cancer. All right. So with the septal thinning and with the ENT and stuff, what we would think is when there is an inflammation, we would think of Wegener's. Wegener's is something which arises in the nose with septal thinning. There is a lot of destruction there. And then obviously orbital inflammation. So there was an inframedial mass palpated, okay? It is right here. Very subtle mass which is seen over here, non-tender, immobile, and she has watering. So when she was referred to me, she was referred as a case of dacryocystitis, okay? Well, I did syringing. It was freely patent. We did CT DCG, which was not with a normal limit. So it's definitely not dacryocystitis. But there is some mass sitting over there. So what would I do? CT was done. There was a polyp in the nose. So the working diagnosis, as I told you, was Wegener's granulomatosis, probably a fungal granuloma or probably a benign tumor, all right? Went ahead doing a surgery. So that is the lesion, which was peri-sac. I could protect the sac, and this was a triangular lesion, a very fleshy lesion which was excised. You know what it came as? Natural killer T-cell lymphoma. peri-sac extension, okay, and she received systemic chemotherapy, SMILE, stereotactic radiotherapy, but she eventually in 8 months developed peritoneal metastasis with CNS involvement. Within 14 months she died. So this was a case which presented as a dacryocystitis, but there was something really hidden inside the orbit, and the polyp that she had, further she went to ENT, the polyp was removed, and that was actually a natural killer T-cell lymphoma again. Alright, so natural killer T-cell lymphoma, it's usually a midline granuloma, lethal granuloma. It arises in the nose and then it extends into the orbit. So, well, it's a very progressive necrotic granuloma, very, very lethal disease. Alright, I'm not going into the detail of it. So, ocular adnexal lymphoma mimics inflammation, and that is why it's an enigma. Biopsy always reveals the mystery. So, whenever you're kind of doubtful or inflammation, you gave steroids, it's recurring, always go for biopsy. Always refer the case if you're not able to manage. It might be something hiding inside. Now, this is a 50-year-old gentleman, pain and redness for 2 years in the right eye. Proptosis, 6 months. Diminution of vision since 1 week. Referred. Well, you know, it's progressing and whatever. So this is what I found, a large lesion in the inferior orbit, and this is a typical kind of a, you know, salmon colored appearance. There is a dilated vessel over here. So you know what, with the imaging, I thought, well, I've cracked it and it's a lymphoma. Alright, very diffuse lesion. We say whenever the lesion actually wraps around the globe, that's a typical imaging appearance of lymphoma, it's lymphoma. So I was like, okay, I cracked the diagnosis clinically. Fine. So I was so confident, but still I wanted to type the lymphoma, etc., etc. And I went ahead with the biopsy. So this lesion was excised with an, you know, inferior pharyngeal approach, and then a little bit of biopsy from this area, and the lacrimal gland was also taken. And this came out to be this. So there's lots of fibrosis over here. There's no atypical small round blue cells over here. There is inflammation, fibrosis, inflammation. Okay, so we did immunohistochemistry. So any very painful, you know, long-standing inflammation of the orbit, a new entity that we often rule out is IgG4 disease. All right, and we do an immunohistochemistry specifically for that, even if it comes as IOID, and this came out to be an IgG4 related disease, and a serum IgG4 was also high. So although it presented and looked like a lymphoma, it turned out to be an inflammation and something very specific. So he was on oral steroids, intravenous methylprednisolone, azathioprine, and he pretty well, you know, responded to the treatment. So this patient was biopsied elsewhere, idiopathic orbital inflammatory disease confirmed, and then he was not responding to the treatment. So he was referred to me. When he presented, his best corrected visual acuity was 6/60. He also had optic neuritis associated with the orbital inflammation, all right? So this is the lateral rectus which was involved. He was already biopsied and proven. Now what happened was that when he came to me, he had already received 2.5 grams of IV methylprednisolone. We can go up to 7.5. So what I did was, because of the severe unbearable pain and the vision, the optic neuritis, I started him on IVMP again, all right? He was responding for some time, but he progressed. He came out with a superior orbital fissure syndrome and an orbital apex syndrome, something like a Tolosa hunt. Very severe pain, complete ptosis. The eyeball was not moving because of the superior orbital fissure syndrome. Now, I'm in a fix, whether we are missing a diagnosis, whether something more is happening inside. I went again inside, okay? I took a biopsy, a superficial, a deepest, how much ever tissue that I could get. And this came out as an orbit IgG4 disease. What happened initially was only a basic histopathology was done. They never ever expected about an IgG4 disease. So immunohistochemistry was not done. A serum IgG4 was also not done. So this turned out to be an orbital IgG4 disease, which was fast progressing, involving optic neuritis. In fact, he's with injection rituximab. He's doing pretty well. I don't have his current picture, but everything is feeling better, and he's 6/6 vision with normal color vision. So this is something that I really wanted to highlight, especially with the PGs. So it's just not IOIDs that we talk about now. There is another entity called IgG4 disease also. So orbital inflammatory disease, to summarize, there is specific and non-specific. Specifics you have to always rule out. If you don't have the specifics in your hand, then it becomes a non-specific idiopathic orbital inflammatory disease. And you know what? 30 to 40% of biopsied inflammation has a specific disorder. So if there is something which is not responding, it's recurring, it's always good to take out a biopsy and prove the diagnosis. So the take-home message is it can present a various clinical presentation, inflammation versus malignancy, malignancy versus inflammation, specific diseases, and all these things have to be ruled out, and a thorough systemic evaluation, depending upon the specificities, has to be done. Thank you so much for your patient listening.